Thank you for that introduction, Roger, and thank you, Wendy, and the department for the invitation. I'm truly humbled and honored to be delivering this John Masterton Public Lecture tonight. And thank you all for taking the evening off to come and have a pleasant time here. So I would like to begin with some disclaimers. So the information you're going to hear tonight is not to be used as medical advice. It's just general knowledge, and hopefully you'll pick up some pieces of information for your next pub trivia. And I would also like to acknowledge my affiliations and funding sources. And given that this is a John Masterton Public Lecture, and I never had the pleasure of meeting the great man, but I know that he was a big history buff. So there's going to be a fair bit of thyroid surgery history in the lecture. So throughout human history, throughout various times and various civilizations, as you can see from these artifacts and artwork, that thyroid disease has been a prevalent condition. And you can see in these sculptures and paintings that thyroid is part of the way of life. And throughout this evening's lecture, I would like to convey a few key messages. I would like to tell you about the surgical advancements over the last 150 years in thyroid surgery. I would then like to take you through what kind of innovative research that is happening these days, and also how we are heading towards a patient-centered care model. But let's start from the beginning. What is the thyroid gland and how does it become diseased? The thyroid gland, the word thyroid comes from the Greek word thyrios, which literally means shield, because to some people the thyroid gland looks like the shape of a shield. But to me, the thyroid is more like a butterfly, and it sits in front of the windpipe, just at the base of the neck. And for a normal thyroid gland, each lobe or each side should be the size of your thumb. If you put your two thumbs together, that's how big your thyroid is. The main function of the thyroid gland is to produce thyroid hormone, which is made from iodine, and it's essential for life. Thyroid hormone maintains the metabolism, controls the metabolism of every single cell in our body. So it is very important. Thyroid also makes another hormone called calcitonin, which controls the calcium metabolism or the calcium levels in our blood. However, it just plays a part in that. It is not essential for that function. Thyroid can be diseased in a couple of different ways. It can grow lumps in it, either a single nodule, or we call these lumps nodules, single nodules or multiple nodules. They can range from tiny ones, millimeters in size, to massive ones. Fortunately, only about 5 to 8 or less than 10% of these nodules end up being cancerous. The thyroid gland can also be diseased if it becomes overactive, such as in Graves' disease, or underactive, such as in Hashimoto's thyroiditis. I will not talk anymore about these functional disorders. We'll focus on the thyroid lumps, in particular the cancerous ones tonight. Billroth was a famous surgeon in the late 1800s. He once said that only the man who is familiar with the art and science of the past is competent to aid in its progress in the future. So let me take you back to the history of thyroid surgery. The first documented thyroid surgery were performed in the 12th and 13th century, pretty rudimentary stuff. There were three main techniques used at the time. If the thyroid hang down on a stalk, they used to use setons or ligatures and to tie off that stalk, and hopefully that bit of the thyroid would atrophy. Probably not all that successful. Sometimes the surgeon would cut into these lumps. If it was cystic or filled with fluid, in other words, the lump might subside. For those who couldn't afford proper surgery, they also used corrosives or things to burn off these lumps, much like burning off skin warts. Suffice to say, things weren't very successful, and people describe these procedures as horrid butchery. And Sam Gross once said, "No honest and sensible surgeon would ever engage in thyroid surgery." How things have changed. I'll show you how. In 1646, a surgeon was imprisoned for performing surgery on the thyroid gland. Now, the reason why I put up this picture of the Taj Mahal not only because it's a beautiful building, it was built in the mid-1600s. So when we were able to build something like the Taj Mahal, we couldn't perform surgery on the thyroid gland. In 1808, Dubutron, another famous surgeon from Paris, performed the first documented total thyroidectomy. And in 1909, the year after he's documented his first total thyroidectomy, Arc de Triomphe was completed. In his documentation, it said, although there was little blood loss, the patient died from shock. So it's one of those classic situations where the operation went really well, but the patient didn't survive. So by 1850, there was a total ban of these operations by the French Academy of Medicine. So this is what was happening in Europe. Meanwhile, in the pre-1850s in China, there was a portrait artist by the name of Lam Qua. He was documenting all these massive goiters and tumors of patients who came to seek the help of Dr. Peter Parker, who was an American medical missionary. And in this picture, in his collection, you can see that this woman has a massive goiter that hung down to her waist. So this is all before the mid-1800s. From then on, things really took off for thyroid surgery. It was one of those things where all the stars aligned. There were various medical and surgical advances that had propelled thyroid surgery into the modern era. I would like to go through some of these with you tonight. There are 3 advances to surgery in general and 3 advances specifically to thyroid surgery. In 1846, William Morton demonstrated for the first time the use of ether anesthetic to perform an operation under general anesthesia. And that was done at the Massachusetts General Hospital, at Mass General in Boston. And that particular lecture theater there is now known as the Ether Dome, where he did this demonstration. In 1867, Joseph Lister introduced the concept of antisepsis. He observed in obstetricians that the obstetricians who wash their hands between patients, between deliveries, the death rate of the infants as well as the patients reduced. So he introduced hand washing to surgery. On top of that, he also introduced carbolic acid by spraying it over the operation site, and the infection rate post-thyroidectomy or post-surgery dramatically reduced. So apart from infection, massive bleeding or hemorrhage it was another thing that deterred surgeons from performing thyroid surgery, given that the thyroid is a gland with a lot of blood flow through it. So in 1874, Thomas Spencer Wells introduced the humble hemostat to the operating room. A picture of a modern version of that is shown here. So it's basically like a small pair of pliers with the locking mechanism in the handle. So it allows surgeons to control the bleeding and then ligate or tie off the vessels in an unhurried manner. So with these 3 advances to surgery in general, anesthesia, antisepsis, and hemorrhage control, the scene is set for thyroid surgery to further advance. Emil Theodor Kocher, or more commonly known as Theodor Kocher, was the chair of surgery in Bern in Switzerland. When he became the chair of surgery, when he started performing thyroid surgery, the mortality rate, meaning if you were having thyroid surgery at the time, there was 4 out of 10 patients died after surgery, either from infection or bleeding or other causes. Within his first 100 cases, he slashed that, sorry about the pun, he slashed that mortality rate to about 13%. And throughout his career, he performed over 5,000 cases of thyroid operations, and by the end of his career, his mortality rate was less than 0.5%, pretty close to what we can achieve these days, which is pretty much close to 0. However, reducing the mortality rate wasn't his only and wasn't even his biggest contribution to thyroid surgery. He performed his first total thyroidectomy, meaning the removal of the entire thyroid, not just part of it. He performed his first total thyroidectomy in this lady by the name of Maria Rischel, when this young girl was only 11 years old, pictured here as the older girl in the picture. He then came across Maria and her younger sister, I'm not sure what her name was, 9 years later. He then realized that while Maria's younger sister during these 9 years has blossomed into this beautiful young woman, Maria's stature remained short and her mentation was quite slow. She was cretinoid looking. So he was really disappointed. He was very confused as to what was going on. At the time, people thought the thyroid was actually a functionless gland. We had no idea what the function did, but we took it out anyway. So he was very disappointed. He went back and recalled 18 of the patients who he's performed this operation on, and 16 of them looked exactly just like Maria with growth retardation, mental retardation, and he was truly disappointed, and he stopped doing that operation altogether. He coined the term cachexia strumi-priva, which is what we now know as hypothyroidism, so underactive thyroid, and what he was seeing was just a very severe form of it. So for this discovery and his careful record keeping of his 5,000 patients, he was awarded the 1909 Nobel Prize in Medicine and Physiology. He was the first surgeon to be awarded this prize, but he was not the only surgeon. Many other surgeons have followed in his footsteps and be awarded the Nobel Prize since then. So that was about the thyroid function. It wasn't until the early 1900s that thyroid extracts were produced and we were able to treat this condition. Next, I would like to tell you about the parathyroid glands. The parathyroid glands are 4 little glands that live just behind the thyroid gland. They are each of them about the size of a grain of rice. And their sole function is to control the calcium level, the calcium balance within our blood, which is very important. And you might be wondering why I've got a picture of the one-horned Indian rhinoceros here. That is because in 1852, Sir Richard Owen, who was a comparative anatomist, or an anatomist who compared different anatomy of different species, he did an autopsy on an Indian one-horned rhinoceros who died in the London Zoo. He discovered for the first time that these little glands behind the thyroid that nobody else has ever described before. In fact, that was the first time parathyroid glands were discovered. And it turns out that the parathyroid gland was the last visible gland to be discovered in any mammals. It wasn't until almost 30 years later a Swedish medical student, Eva Sandström, then dissected out and described in detail these same glands in humans. So how does that relate to thyroid surgery? I would like you to meet William Halstead, who is another famous surgeon. He's from America. He has traveled around the world observing other surgeons perform surgery. He made some comments regarding the techniques of Cocker, who we have met, and Bjoroth, whose quote we started with this evening. About Cocker's technique on thyroid surgery, he said he was neat and precise, operating in a relatively bloodless manner, scrupulously removed the entire thyroid gland, doing little damage outside the capsule. So he liked the way he operated. About Bjoroth's operating, he said he was operating more rapidly, with less regard for tissues and less concern for hemorrhage, might easily have removed the parathyroids or at least interfered with their blood supply. So very profound statements. Around that same time, Bjoroth's students realized that a lot of his patients after total thyroidectomy were suffering from this technique, severe spasm of the muscle all over the body. They had no idea what was going on. But the medical students here today would know that it is because the parathyroid glands have been damaged, the calcium levels has dropped dramatically in the blood and causes spasms of the muscles. And the day after thyroid surgery, I'm sure all the interns and medical students run around the ward checking for carpal pedal spasms. And it wasn't until, although they've made that connection, it wasn't until 1891, so another decade later, that it was realized that the techniques were due to the injury to parathyroid glands. So now that we've discovered that, there were ways of treating it by giving these patients calcium supplements. I don't want you to get the wrong idea about Birol. He was an excellent surgeon. He was internationally renowned. He was an innovative surgeon. He was the first to perform many of these difficult and complicated operations, including laryngectomy, gastrectomy, esophagectomy, and pancreatectomy. So that was parathyroid, the discovery of parathyroid glands. Next, I would like to talk to you about this lady, Emilita Galli-Curci. She was regarded as the best soprano in the world in the early 1900s. As you can see from this picture here, over a 15-year period, she developed quite a goiter, which she nicknamed the potato. Because she was a singer and she knew that many patients who undergo thyroid surgery have their voice affected. So she really didn't want to have surgery on her thyroid until she could barely breathe. She couldn't sing anymore. She then underwent removal of her thyroid. And one day after her operation, as depicted in the picture on the right here, she was so thrilled that she could breathe again, she could sing again, and her voice, she thought, wasn't affected. After a period of retraining, she got back on the stage. Unfortunately, the critics didn't like her anymore. They thought she sounded horrible, and within 3 years, her career was ended. So this highlighted the importance of preserving the nerves to the vocal cords during thyroid surgery, because they come really close to the thyroid. And because of patients like this, methods and techniques were developed to protect all 4 of these nerves. So there we have it. So in the late 1800s and the early 1900s, thyroid surgery really came of age with advances in surgery in general and also specific advances to thyroid surgery. So from the statement of it being a horrid butchery, Halsted made this statement about thyroid surgery. He said the extirpation of the thyroid gland typifies perhaps better than any operation the supreme triumph of the surgeon's art. And I would like to point out to you that this spirit of innovation amongst thyroid surgeons was evident and fruitful over 150 years ago, and that continues today. I would like to change our attention and tell you a little bit about thyroid cancer. So this graph shows the percentage change in the incidence of cancer diagnosis. And I know that words are pretty small, but just let me show you that thyroid has the highest increase in incidence amongst all these cancers listed here. And right here in Victoria, there was a 4.5 times increase in the diagnosis of thyroid cancer during that same 40-year period. Less so for men, but still very significant. But fortunately, as depicted by the dotted lines here, the mortality rate remained low. So now, in Australia, thyroid cancer is the 7th most commonly diagnosed cancer in women. Fortunately, it doesn't make the top 10 in men. And breaking that down to age groups, thyroid cancer is the most commonly diagnosed cancer in women between the age of 25 and 29. Breaking that down further, it is the #1 diagnosed cancer in Victoria in girls between 15 and 24, in women between so number 4 in women between the ages of 25 and 59. And as I mentioned before, it has a very good survival rate. It has the highest 5-year survival rate amongst the top 10 cancers in women, and because it's not one of the top 10 cancers in men, it doesn't show on this graph. So what does all that statistics mean? To me, it's saying to me that the incidence of thyroid cancer has increased dramatically over the last few decades. It is also saying to me that it is now the commonest cancer in women of childbearing age. Although it has an excellent survival rate, it means that there are many patients living with the cancer or in fear of the cancer coming back, and we'll touch on that a little bit later on as well. And what that means to me also is that we need to focus our research not just on improving the survival of these patients, but also the quality of life of these patients. I would like to remind you that although we use the term thyroid cancer is not one disease. It is a spectrum of disease, both in pathology and its behavior. Don't worry about the text in this slide. Just focus on the different colors. Each, on the pie chart on the left, each color represents a different type of thyroid cancer. And of the most common type, which is in green, the right-hand pie chart then represents the different subtypes. And these are just general subtypes. So there are many, many other types that can be subdivided from here. So that creates a bit of an issue for us when we're managing these patients. I would now like to take you through the sort of general journey that a patient goes through when they're being diagnosed with thyroid cancer. They usually present in one of two ways. They either notice a lump in their neck, or their lump in the thyroid is noted on some sort of scan that they do unrelated to the thyroid. They can have an ultrasound for the carotids, or a CT scan for the neck, or MRI, etc. Regardless of how they present or how they find their lump, they need careful clinical examination and assessment, and further detailed investigation or detailed imaging with ultrasound. And if appropriate, they would be recommended to have a needle biopsy, which is the biopsy sample is then looked at under the microscope, and this is the sort of thing the pathologist would see, and we call that cytology. So once the patient has undergone the series of investigations and have a biopsy sample, about 70% of them would be diagnosed as non-cancerous, so they're benign, so everybody's happy. But unfortunately, as I mentioned before, about 10% or just under will be diagnosed with cancer. Although that is not good news, at least we know what we're dealing with, and we can come up with a plan. We can recommend surgery or not, depending on other factors. And if we do recommend surgery, we can then determine the amount, the extent of surgery that these patients need, because we have a diagnosis, benign or malignant. But if you do your maths right, you're probably thinking, well, where's the rest of them? Well, you will be right in asking that. About 25% of the time, even with the needle biopsy samples, we're not able to tell whether this lump is malignant, whether this lump is cancerous or not. I will come back to this group a little bit later on with the indeterminate cytology, but now I just want to focus on those patients who have just been diagnosed with cancer. So in this day and age, the mainstay of treatment for thyroid cancer is surgery, removal of the thyroid. Not the kind of surgery we were talking about before, but modern surgery, done usually under general anesthesia. Most surgeons now perform what we call sutureless thyroidectomy, where the vessels are sealed by high-tech heat devices. We monitor the nerves to the vocal cords during the operation. We monitor the parathyroid levels, the calcium levels after the operation, and treat them appropriately before any symptoms develop. We replace the thyroid hormone treatment straight away after surgery, and it's usually overnight or sometimes day surgery if it's a partial removal of the thyroid. We can achieve excellent results. Long-term parathyroid damage, less than 1%. Bleeding after the surgery requiring return to the operating room, also less than 1%. And long-term injury to the vocal cords, also less than 1%. So after the thyroid operation, we then examine the whole specimen under the microscope, and we can get a lot more information from that specimen about their disease. So what happens next is what we call a multidisciplinary team meeting, where lots of different experts come together in the one room and discuss every single thyroid cancer patient that comes through our door. They include radiologists, pathologists, endocrinologists, nuclear medicine physicians, surgeons, nurses, and our trainees and students. And this is an actual picture. Look at how happy everyone is. So what sort of thing do we discuss in this forum? We review everything, all the information we have. We review all the imaging, review the initial needle biopsy result, we review the surgical specimen, we review all the blood results we have, and radioactive iodine scan if that has already been done. We then discuss what staging the cancer is, and the current response to treatment, and the pros and cons of various other treatment options. And then we make recommendations as a group consensus. We will recommend whether they need further surgery, whether they need further treatment with radioactive iodine, or how should they and how often should they be followed up. I just want to say a few things about radioactive iodine. It's the isotope is 131 iodine. It was first used in the 1930s. It was originally intended for the treatment of hyperactive thyroid glands. But it was discovered that higher doses, it would actually kill the cells that concentrate iodine, which are unfortunately for us, that's the only cells that concentrate iodine in our body are the thyroid cells and the cancers that come from it. So it's also known as radioactive eraser or the gamma knife. So once the patients have had their surgery, plus minus the radioactive iodine treatment, we then categorize them into risk groups. And these risk groups refers to the risk of the cancer coming back. So they can be low risk, medium risk, or high risk. And depending on that, we then recommend how and when they should be followed up, how often and how they should be followed up. And all thyroid cancer patients need to be followed up long term, because if you follow all of them for the rest of their lives, about 30% of them would get recurrence, meaning the cancer can come back. Doesn't mean that the cancer is going to kill them, but it means that they might need further treatment. So when they come back for their review with more tests done, we get additional information about their response to the treatment we've recommended so far at about the 12 to 18 months time. So at that point, the risk category can be changed. They can be downgraded from a medium risk to a low risk if they've had excellent response to treatment. But conversely, and luckily less often, their risk level can be upgraded from a low risk to a medium risk because they haven't responded as well as we expect with the treatment. So this is what we call dynamic risk stratification. So every time we get new information, we can re-stratify their risk level, which is good, which makes it more accurate as time goes on. But on the flip side, it means there's at least 12 months, if not more, of uncertainty and anxiety on the patient's behalf, sometimes for the rest of their life. And there are some guidelines out there on how we manage these patients. And one of the most commonly used set of guidelines is published by the American Thyroid Association. They first published these guidelines in 1996. At the time, there were 8 pages and 21 references of studies that studied these thyroid cancer patients. And this, don't worry about the text in there, but this is the only figure in that entire 8-page guideline. 13 years later, they updated the guidelines. In 2009, it was 48 pages long. It was 6 times longer. And they refer to more than 400 studies because there's been so many studies, and our knowledge, the information regarding thyroid cancer has increased dramatically. And that same algorithm has now become something that I need a Google Maps to help me navigate. Fast forward another 6 years. In a short 6 years, so first they updated their first revision in 13 years, and then they updated their next revision in a short 6-year period. It's now 133 pages, over 1,000 references within that document, and thankfully they have pulled back on the complexity of that algorithm. So as you can see, there's a lot of information out there about how to manage these patients. It's not possible for one person to be comfortable with everything, and that's why we come together as a group of experts to manage these patients as a team. And as I was saying before, even though there's only less than 10% of these thyroid nodules are cancerous, thyroid nodules are actually very common. In a room of, say, 100 people like here, 65 of them would have thyroid cancers. Thyroid nodules, but only less than 10% of those would be malignant, which means that there are many, many thyroid nodules or thyroid lumps and goiters which all need careful assessment. It's a bit, in my mind, it's a bit like Where's Wally? You know, everything is like red and white, and where is the cancer nodule that you're looking for? Now, I have introduced to you this evening lots of famous people from the past. I want to introduce you to a couple more people closer to where we are now. This is Rob. He's a 50-year-old mechanic. Unfortunately, he fell off a ladder at work one day, was sent into the emergency department. He had a CT head and neck, a CAT scan of the head and neck to look for any injuries. Luckily, he didn't injure himself. But incidentally, they found this 2.5 centimeter lump in his nodule. He was then recommended to have a biopsy done, and the biopsy came back indeterminate. Remember indeterminate, the middle group that we don't quite know what it means? And then there was Angela. She's a 43-year-old lawyer. She is very hardworking. She works long hours because she's hoping to become a partner in her firm within the next 12 months. She went to her GP because she can see this lump in her neck, even just in the mirror. She then had an ultrasound which showed that this lump came from the thyroid, 4 centimeters in size, and she was also recommended to have a biopsy. Again, she had a biopsy result that said indeterminate. We don't know what to do with these. So they both went and saw a thyroid surgeon, and they were both recommended to have half of their thyroid removed just for the diagnosis. Now that sounds simple, but that means general anesthetics, an operation just for the diagnosis, okay? So Rob and Angela's situation is not uncommon. Of all the biopsies that we do of the thyroid with the needle biopsies, about 25%, the range is about 20 to 40 depending on the circumstances. About 25, on average, 25% of them are indeterminate. And of all these indeterminate ones, the risk of cancer is also about 25%. So let me illustrate what that means. And most of these people would need surgery for their diagnosis, like Rob and Angela. So of those people that have surgery, 70% of them just need to have half of the thyroid out. But the other 30% might have their whole thyroid removed for other reasons, if there are other nodules or if the thyroid is not working well anyway. And as I was saying before, 25% of them would eventually be diagnosed with cancer. And unfortunately, Angela fell into that 25%. What does that mean? That means that she only had half of her thyroid removed. She needed to go back to have more surgery to have the rest of her thyroid removed because we didn't have the diagnosis to begin with. On the other hand, Robert was a little bit more lucky. He didn't have an injury from his fall, and he didn't have cancer in his thyroid. But is that lucky to have go through surgery, just to be told that, oh, everything's fine? Do you think he's had surgery unnecessarily? So overall, about up to 25% of these patients get the right amount of surgery the first time around. But in these patients with indeterminate biopsies, about 75% of them either have too much surgery or not enough surgery initially. So that's another challenge in managing these thyroid patients these days, are these indeterminate diagnoses, which impedes our ability to plan surgery and may lead to suboptimal treatment. So what can we and what are we doing about this? I would like to introduce to you, if you haven't come across this concept before, the concept of precision medicine, which is defined as tailoring of medical treatment to the individual characteristics of each patient. So to each individual patient, not just groups of patients. Let me illustrate this for you. In the past, we practiced what we call one-size-fits-all medicine. So everyone with thyroid cancer will end up having a total thyroidectomy and radioactive iodine ablation. And for about a third of them, that will be the perfect amount of treatment they need. But for some of them, it will be over-treatment, and the rest will be under-treatment. And this is what we practice now, which is stratified medicine. We group patients into groups based on the knowledge that we have. So in terms of thyroid cancer surgery, we determine or we recommend the extent of the surgery based on the size of the cancer or size of the tumor that we can see on the ultrasound, or whether there's any involvement or spread to the lymph glands in the neck. And for the majority of patients, we're able to recommend the exact amount of surgery they need. But for a small percentage like Angela, we don't recommend enough. And for the other small percentage like Rob, we recommend too much surgery. So we would now like to move into the next concept of medicine, which is the precision medicine. We are moving towards this at the moment. Not only do we recommend surgery depending on the size of the cancer, whether there's any lymph node spread, we can also recommend surgery and further treatment based on the biology of the cancer, of the disease, or the likely effectiveness of the treatment, with the hope that everyone gets individualized treatment plans and everyone gets the right amount of treatment they need. And how do we achieve that? How do we study how do we learn about the biology of the cancer? And that is through studying the genetics of thyroid cancer. To study the genetics of thyroid cancer, we use a technique called sequencing. Traditionally, sequencing was a very time-consuming and costly exercise. because each gene, there are thousands of genes, there are thousands of different possible mutations or alterations to the genes that we need to examine, and we can only look at one gene or one alteration at a time. It was time-consuming, costly, and required a large amount of material, which usually means that you have to have the cancer removed from the patient before we're able to do that. But over the last couple of decades, with the improvement in technology and computing power, we are now in the phase of next-generation sequencing, which is also known as massively parallel sequencing. And as the term suggests, the sequencing of genes and mutations happen parallel, tens and thousands at a time. And this fast turnaround time allows us to actually apply this technique into the clinical setting. And the cost of it is rapidly dropping, making it more accessible to patients. And much less material is required with this new technology, which means that we may be able to use this on their specimen, or this biopsy specimen with a needle biopsy before they undergo surgery. In my mind, it's sort of like the old toll booth where every car has to stop, pay the toll, get their change, then move on. Whereas the new technology is like the e-tag, multi-lane e-tag, where the cars zoom through and your money just gets taken out of your pocket without you knowing, and you don't even have to stop. So the first thing we do, now that we've got the technology, the first thing we need to do is to map out all the different possible combinations, the different changes to the genes of all different thyroid cancers. Luckily, that process has already begun. This group, the Cancer Genome Atlas Project, published in 2014 the results of their study. And they call this the landscape of thyroid cancer gene alterations, meaning that they took hundreds of patient samples. So all the spikes up the top, don't worry about the length of the spikes, but each spike represents samples from one patient. So there are hundreds of them. I think there were like 480 of them. And then they looked at all the possible genes that can cause cancer or that can be associated with cancer that we know of. And this is just a short list of them. So they looked at each individual tumor and looked at every individual gene, and then they map it out. So whenever they find an alteration or change or something abnormality, they draw a little color spot on there. And you will notice that most cancers would have at least one alteration within the tumor. But there are some with no alterations. We don't really know what that means, just because we haven't discovered those alterations. They actually don't have alterations, or are we not looking hard enough for the alterations that are actually there? And you will also notice that some tumors would have more than one alteration, so multiple alterations. And we are also just learning what that means. So over the last 10 years, in 2007, this group, who is one of the leading groups in this technology in thyroid cancer from Pittsburgh in the United States, in 2007, they were able to find gene alterations in up to 65% of thyroid cancer tumors that they had. And fast forward 10 years, and now they're on to their third iteration of their test. They can now detect an alteration in more than 95% of these thyroid cancer tumors. What that actually means in terms of patient management, how does that change patient management, requires a lot more work. Now, that's all good and well, all these genetic mutation, molecular mumbo jumbo. What does it actually mean for people like Angela and Rob? Now, as we saw before, they fell into that 75% who had suboptimal surgery to begin with, needed more surgery later on, or might have not needed the surgery at all. Now, with this new technology, by knowing these patients' individual genetic codes before surgery, the aim is that we can tailor their treatment for each individual patient based on their exact tumor from the biopsy that we get. And so that most patients would end up with optimal surgery to begin with. And that is what I mean by precision medicine. And that's just scratching the surface. Confirming or excluding cancer before surgery is just one of the potential utility of precision medicine in thyroid cancer. We hope to be able to predict aggressive behavior before surgery. So I mentioned to you before, some tumors have more than one alterations, and sometimes that actually means that the tumor is more aggressive. We hope to also be able to predict whether a tumor is going to be sensitive to radioactive iodine, which means that we know whether we need to be aggressive with the surgery to start with, or we can leave the rest to be treated with radioactive iodine. And even within those aggressive ones, we may be able to tell from the pattern of their gene alterations whether they're more likely to have the cancer come back in the neck or come back somewhere else in the body. We can also try and target these mutations by developing medicines to fix these alterations. Or on the other end of the spectrum, we might be able to say to a patient, well, your tumor is so low risk that we don't even need to see you anymore. But we're not able to give that sort of assurance at the moment. So I think we all need to move forward and classify in our minds and in practice, classify thyroid cancers according to genetic alterations in addition to their appearance under the microscope, which is mainly what we're doing at the moment. So I just want to bring us back, revisit Angela's journey Angela's journey of thyroid cancer treatment. But now I want to try and show you things from a slightly different perspective. I've been telling you how well we're doing and how well we're gonna do, but what does Angela think about that? Now, as I mentioned before, thyroid surgery is often just overnight surgery, and Angela would have been told that. A surgeon says it's just overnight surgery, and she's thinking, well, I'm about to make partner in my firm. I can't afford one night off, let alone 3 weeks off work. We're very good with our surgery. The complication rate is less than 1%. And she's thinking, well, what, I'm in the one? Like, statistics don't mean anything to me. After thyroid is removed, to replace the hormone, it's usually just 1 tablet a day. It's very easy. Well, she's thinking, well, that means that I'll be reminded every single day when I take this tablet that I'm living with thyroid cancer. Survival rate is excellent, 10-year survival rate of over 95%. Well, that means I've got like a 5% chance of being dead before I'm 55. That's not very good. So I just want to illustrate to you that although we think we're doing really well, and then we are, but from the patient's perspective, we can always do better. In fact, there was a study published in the World Journal of Surgery in 2015 looking at the quality of life of cancer survivors, including thyroid cancer. And we all think thyroid cancer not very aggressive, not many people die from it, they must be fine. Well, this study looked at multiple domains, physical, psychological, social, and spiritual, and then give them an overall score. Interestingly, they found that the quality of life in thyroid cancers is the same, if not worse, compared to bowel, gynecological, brain cancers, and breast cancer. Just to delve into it a little bit more, compared to bowel and gynae cancer survivors, thyroid cancer survivors were worse in the spiritual domain. Compared to brain cancers, thyroid cancer survivors were worse in the physical and spiritual domain. And compared to breast, another common cancer that affects women, thyroid cancer patients actually scored worse in every single domain that they studied. Interesting. We have very similar experience here at the Alfred in that what we measure as clinician researchers, what we think we're doing well, not necessarily what the patients think. In 2016, we published this study on the effect of thyroidectomy, thyroid surgery on the voice. We measured the quality of the voice in 2 ways. One is by an objective measure done by a speech pathologist, and then we asked the patients what they thought about their voice. In total thyroidectomies, both the objective and the subjective results were similar. However, interestingly, when only half of the thyroid was removed, the researchers were not able to measure any change in the patient's voice, but the patients actually complained of significant change to their voice. So it begs the question: are we measuring the right things? Are we measuring what matters to the patients? Another example just published earlier this year. A lot of patients come to us as thyroid surgeons saying, oh, am I going to put on weight after I have my thyroid surgery? So we just thought, well, we need some evidence to tell them that actually that's not true. So we did this study and we found that, yes, some people did a small amount of people put on a little bit of weight, others lost some weight, so on average there was no significant change to their weight. What we also did in this study is we asked the patients how satisfied they were with their whole sort of thyroid surgery experience. And again, this was a bit of a surprise to me. After having the whole thyroid removed, weight change happened in a few, and it was unpredictable, but whether they gained or lost weight had nothing to do with how satisfied they were with the whole experience. Again, by measuring, are we measuring the right things? Measuring their weight, was that what they're worried about? Or should we be more concerned about what the patient experiences? So I would now like to just to finish up, to let you know what sort of research is happening right here in Victoria and also here at the Alfred. So the Alfred, along with other hospitals that I work at, have a long tradition of clinical research. We've published many papers and we're really proud of that. Over the last couple of years, the ANZ, so a binational thyroid cancer registry, has been set up, much to the hard work of Leanne up there. And that has allowed us to further our clinical research, but it has also allowed us to focus more on patient cancer outcome research, patient-centered outcomes research, because we now have a central repository of all these patients and we keep track of them and we're able to follow them up. And in addition, in the last 12 months or so, I have been able to establish collaboration with laboratories at Peter Mac, at Monash University, to look at some more translational and basic science thyroid cancer research. And I'm fortunate to be funded by the Epworth Research Institute, Perpetual Philanthropy, and the Aftershock, which is a non-profit organization. But what are we doing all this for? Of course, we're doing all this to improve our ability to care for our patients, so that one day in the near future, we're able to say to Angela or people like Angela, fine, you've got thyroid cancer, it's okay. We can design a treatment that is just right for you. So to conclude, I would like to say it's taken us 150 years of medical and surgical advances to where we are now with thyroid surgery and the management of thyroid cancer. It is our obligation to carry on the legacy of our predecessors in this field, to continue with innovations in both surgical techniques and in thyroid cancer research. But above all, we should not lose sight of what we're doing all this for, and that is for our patients. So I believe that the future of thyroid cancer management and thyroid surgery is very exciting here in Victoria. We are on the cusp of the next big thing, and I'm really thrilled to be part of this evolution. I would just like to leave you with this quote: whether you believe you can do it or not, you are right, and I believe we can do it together in Victoria. Once again, I would like to thank my funding bodies, my research partners, and most of all, where I get my inspiration from, and that's my patients. Thank you very much for your attention.